It is now my pleasure to turn today's program over to Charles Glock. Charles, the floor is yours.
Thank you, Ian. Hello, everyone. Thank you for joining us. I want to welcome you to today, our first webinar in the 5-part Care Delivery Orientation Series. Today's webinar is focused on access and continuity. For our newest CPC Plus participants, please type in your questions throughout the webinar. We'll get to as many as we can, and for those we aren't able to answer, we'll provide additional information on CPC Plus Connect, and we'll also put it in the frequently asked questions section on the Plus Side newsletter. Now I'm going to turn it over to Joe Grundy, who will lead us through the rest of the session. Joe?
Thanks, Charles. Hi, everyone. Thank you all again for joining us today. We're really excited to welcome you and your practices to the first Care Delivery Function Orientation webinar. This is the first of 5 weekly webinars. This week, as Charles mentioned, we'll be focusing on Function 1, Access and Continuity. I'll be serving as one of your facilitators today. I'll be joined by my colleague, Jen Miller of the CPC Plus National Learning Team. We'll also be joined by one of your fellow CPC Plus participants, Ms. Amanda Holt, who we will introduce momentarily. Through the course of this series, we really do want to draw upon the experiences and perspectives of existing CPC Plus practices as much as possible. Amanda will be joining in our discussions regarding various aspects of access and continuity throughout the discussions. We'll have dedicated time towards the close of today's session for you to ask questions to Ms. Holt directly. And on that note, as a reminder, you can submit questions or comments at any time during the webinar using the Q&A pod that you should see on your webinar window. It is with sincere pleasure that I introduce Ms. Amanda Holt, who will be sharing just some of the many awesome activities that St. Luke's Primary Care Mission Farms has taken on to improve access and continuity as a CPC Plus practice site. Amanda, first, could you just take 10 or 15 seconds to tell us about St. Luke's Mission Farms?
Absolutely. Thank you, Joe. As Joe mentioned, I am Amanda Holt, and I have the pleasure of serving as Director of Patient Care Transformation at St. Luke's Health System in our Primary Care Division. We have 10 practices that are participating in CPC Plus, and today I'll be speaking on behalf of one of those practices located in Leawood, Kansas, our practice that we call Mission Farms. At that particular primary care practice, we have 15 primary care providers, and we serve, as you can see on the slide here, more than 18,000 patients. We are on Epic, and we are a Track 1 practice. And with that, Joe, I'm ready for the next question.
So you're definitely approaching CPC Plus from the perspective of a larger health system. As you share some of St. Luke's initiatives, could you highlight areas that you think other practices, particularly small and or independent practices, could draw on?
Yes, Joe, I think that's a really important question. The first place I'd like to start is just reminding everyone that as you embark on the journey, the multi-year journey that is CPC Plus, that we aren't expected to do everything in year one. So I think even at a large system, we have to remind ourselves of that. So I think, some of the areas you may get started might include things like offering same-day appointments or expanding your clinic hours. You're likely already doing or offering expanded access in one way or another to your patients. So I think it's just a matter of taking a look at where have you already expanded access and how can you build upon that. But one of those, for us here at St. Luke's, I know that one place we started, and this was prior to my tenure here, but one simple way was that we looked at expanding hours, opening and offering appointments as early as 7 a.m. and then offering appointments as late, after 5 p.m. and into the evening hours.
So as a health system, how do you balance managing transformation at the practice level and the need for practice champions with the resources that can be leveraged at the system level, to support data integration, quality improvement, or centralized operations?
Another very good question, and one that we receive on a regular basis. at St. Luke's, this is very much a team-based effort. And when we look at how do we balance our system-level resources with those important staff members on the ground at the clinic level, what we have done is make sure that we have a presence at every single monthly practice manager meeting, at every clinical supervisor meeting, and every physician chair meeting. There is discussion each month looking at our participation in CPC Plus. Our practice managers, for example, are the people who complete the quarterly care delivery reporting for their practice. And then at the system level, what we do is we provide the support. We are able to run the reports to obtain the data they need to complete that reporting. So it has very much become a balanced effort between the system and the practice managers.
Thank you. So final question, for the moment at least. Could you share any specific stories about how working to improve access to care and continuity have directly impacted your practice and your patients?
Yes, I would be happy to share. And I am grateful for the fact that I could share numerous examples, but to start with just one, I'm really proud of the work we've done to both register patients for our patient portal and to then increase utilization of the portal. And to share one recent patient testimony, actually just last week we hosted our Patient and Family Advisory Council meeting at Mission Farms, and one of the areas that came up, of course, was our portal. One of the gentlemen serving on that committee commended us, and he really appreciated the ability to message his primary care provider directly when he's out of town. He happens to be a patient who travels on a regular basis for his job, and there have been a couple of times that he noted where he was able to message his provider directly, which then prevented him from having to seek care at a clinic, in Los Angeles or wherever else in the country he may have been for work.
That's awesome, and that actually goes towards the fact that, in meeting every aspect of the goals of comprehensive primary care, plus they address the triple aims of improving the quality of care that's delivered, improving the patient experience of care, and addressing resource utilization as well. So thank you so much for that story. This image, the driver diagram, represents the conceptual framework for CPC Plus. The drivers are the 5 key strategies that together support the CPC Plus goals of achieving better care, improving health outcomes, and being smarter about how we spend healthcare resources to achieve optimal outcomes. The primary driver, the comprehensive primary care functions in blue, are supported by 3 foundational drivers: the use of enhanced accountable payments in green, the continuous improvements driven by data in orange, and the optimal use of health IT in red. Supporting this comprehensive model of change is aligned payment reform in purple. All of you starting in 2018 have the added benefit of all that was learned during program year 1. So as we go through some of the foundational elements of the driver diagram, we will talk through and highlight some of the high impact changes that our 2017 starting practices identified and really kind of precipitated for us. Of course, we know that all of you have already been making improvements to your practice. Some of you will have already accomplished some of the things that we'll be describing, and that's great. You'll see that this model is designed to be flexible and allow you to prioritize your quality improvement work to best meet the needs of your practice and your patient population. One thing that we cannot emphasize enough is that there is no one correct, one-size-fits-all answer for any change process. You, participants from other CPC Plus practices, CMS, and the members of the learning networks are all co-investigators in this work. We'll all be learning from one another to identify what strategies are most impactful in making patient experience better, improving the quality of care, and lowering cost. For this series of webinars, we'll focus on the 5 comprehensive primary care functions. These are the aspects of practice transformation that will most directly impact the daily flow and life of patients, practice care teams, and practice staff. You'll also see that most of your care delivery requirements reflect high-impact change tactics aligned to this driver. Each session of this orientation series will describe one of the comprehensive primary care functions to highlight how they and their underlying change concepts are interrelated. During your first year, your practice will be making some pivotal changes that will provide a foundation for the requirements of subsequent program years. One thing that I do want to address up front with you is that, and you'll hear this repeated actually, is that CPC Plus is not a quote-unquote check-the-box compliance model of transformation. You and your practice teams will have to work together to figure out how to develop transformational objectives so that they are both achievable and sustainable in your given practice dynamics. Again, there is no single correct answer for how practices should transform and innovate on any given CPC Plus objective. Here are our goals for this orientation series of webinars. By the time we wrap up all 5 sessions, we will have described the comprehensive primary care functions to ensure that you and your teams understand what the expectations for your first year in CPC Plus are. We will have drawn directly from the experience and successes of CPC Plus practices that started in 2017 to streamline your startup process. And finally, we will have identified key resources that you and your practice can use right off the bat so you don't need to reinvent the wheel. At the end of this session, you'll be able to define and explain the key change concepts of improving access and continuity of care. You'll be able to establish a strategy for developing and optimizing effective empanelment processes for your practice. And you'll be able to describe strategies that help you achieve CPC Plus goals of improved care by expanding access to care and ensuring continuity with the care team. As we shared up front, for today's discussion, we'll be focused on Function 1, access and continuity. Access refers to the timely use of needed health services. Continuity refers to the process by which patients and their care team are cooperatively involved in ongoing healthcare management towards shared goal of high-quality, cost-effective care and better patient experience. Access and continuity are best characterized by the mutual trust and communication between patients, their caregivers, and the care team. This function really is the foundation of effective primary care. So we use the term better balancing timely access and continuity of care for your patients very intentionally. Working to balance the tension between expanding timely access and managing the ongoing processes to ensure continuity for patients is at the very core of the delivery of comprehensive primary care. It may seem counterintuitive, but there really is often a tension between improving access for patients and improving continuity of care for patients. That is, many strategies to improve access may impair continuity, and many strategies to improve continuity of care and relationships may come at the cost of access. For example, patients who are recently hospitalized may need an appointment to facilitate the transition back to primary care when their practitioner happens to not be available. So it's important to consider balancing patient needs and preferences for access with their desire to see the same practitioner. So turning to Amanda, can you tell us a little about how St. Luke's has managed the tension between expanding access and ensuring continuity of care? Working off our example, how do your care teams ensure patients transitioning back to primary care following a hospitalization can connect with their primary care providers in a timely fashion?
Yes, thank you, Joe. Great question. I think, as we look at balancing access and continuity, that is going to be an ever-present challenge. One of the ways that we we work to strike a balance, and the example you provided is that each of our primary care providers has 3 same-day appointment slots that are technically frozen until midnight that morning for immediate use later that day. So that is one way we have expanded access to patients who have an acute need and need to see their provider on a moment's notice. However, we also recognize, as patients are being discharged from the hospital, we need those patients to be able to see the primary care provider for a hospital follow-up visit in a timely fashion. So what we have done is our care coordinators have special secret access to unfreeze one of those same-day appointment slots for specifically so that a recently discharged hospital patient is able to get in to see his or her primary care provider, again, in a timely fashion. So we recognize that while we're using up one of those really important same-day slots that perhaps another patient may need for an acute issue, we are ensuring appropriate continuity for the patient who is just out of the hospital.
So that really is a perfect example of kind of how practices and care teams need to be mindful of how they balance prioritizing access to care versus continuity of care. Because like you said, as you work to ensure that a patient can see their primary care provider, it then eliminates a slot, a same-day slot, for an urgent care patient that may have needed to be seen by that primary care provider. So thank you so much, Amanda. This ties in perfectly. On this slide, you'll actually find a quick overview of how working to improve access and continuity and effectively managing the tension between the two will directly impact your practice. First, the major thing you should see is that you'll see the relationships that your patients have with their care teams and with the practice will be enriched. You'll find that you have a much more accurate understanding of who is and who is not a patient of your practice. You should see some fairly substantive opportunities to improve operations and patient flow at your practice. And finally, you really will be establishing the very basis for all future population health work related that your care teams will be taking forward through CPC+. Quite frankly, everything that we discuss over the next few weeks builds directly upon the work you will be undertaking to address access and continuity. To avoid any confusion, we'll be reviewing all the CPC Plus care delivery requirements for Function 1. Clinical delivery requirements provide a framework for key changes that you will make in your practice, but they are purposely broad so you can innovate based on your resources and the specific needs of your patients. These requirements establish a floor, not a ceiling, of practice transformation and innovation, meaning they will provide you a rough structure to help coordinate your practice transformation, but they do not serve, again, as a minimum check-the-box requirement. Clinical delivery requirements will be updated on an annual basis and build upon themselves as your practice continues to transform through each program year of CPC+. This slide summarizes the Function 1 clinical delivery requirements set for your first year in CPC+. Please note there are requirements that all CPC Plus practices must fulfill, as laid out on the left side of this slide. For Function 1, access and continuity, all practices must achieve and maintain at least 95% empanelment of the patient population to a practitioner and or care teams. They must ensure patients have 24/7 access to a care team practitioner who in turn has real-time access to the EHR and the patient's medical record. And the practice must organize care by practice-identified care teams responsible for a specific identifiable panel of patients to optimize continuity. Practices participating in Track 2 will also need to regularly offer at least one alternative to traditional office visits to increase access to care teams and clinicians in a way that best meets the needs of their specific patient population. To accomplish your access and continuity goals and to achieve more patient-centered, high-quality, cost-effective care for patients and families, you should focus on these three change concepts. Change concepts are the critical overarching objectives that we recommend that you pursue to most effectively innovate on the clinical delivery requirements. First, you should empanel all your patients to a practitioner or care team. Second, provide your patients with expanded access opportunities to care delivery services. Finally, you need to develop a process to evaluate and optimize the continuity of care delivery your practice provides to patients. So starting with empanelment. Empanelment is an important first step so you can assign patients to your practitioners or practice care teams. To accomplish many of the improvements in CPC Plus, you'll need to know who your patients are and then align them to care teams that patients know and can best meet patient needs. Empanelment really forms the foundation of nearly every aspect of population health and your practice's care management capabilities. So let's clarify what we may mean. Empanelment can best be defined as a series of processes that assign each active patient to a practitioner and/or care team with consideration of patient and caregiver preference. Empanelment is not just about the assignments within the EHR, however, or a list within a registry. It is an active, continually updated process meant to ensure patients know who know them and who knows their specific needs. For practitioners, empanelment enables you to provide proactive care to all the members of your panel, not just those who happen to have come in for an in-person visit. So, how should your practice approach empaneling your patients with intentionality and deliberation? First, you'll need to identify all your practice's active patients. Active patients are those who've received primary care services at your practice over a predefined look-back period. This look-back period must be at least 18 months long, but many practices prefer to use either 24 or 36-month-long look-back periods. Your practice will then need to refine how you define which patients are included and which patients are excluded from your active patient list. Then you'll need to develop a process to assign each patient to a practitioner or a care team. Make sure you structure in an opportunity for each practitioner to review his or her empaneled patient list. Almost universally, empanelment for each practitioner is one of those topics that really drives tremendous practitioner engagement through the whole transformational process. By empaneling your patients, you can answer questions like the following. Which patients are active and inactive in our panel? What % of our active patients are assigned to a specific practitioner and/or care team? And are we seeing patients who are not our primary care patients, such as those referred to us by specialty consultation or presenting for urgent care, but rather those receive primary care elsewhere? And are you able to exclude those patients from your empanelment process? So, turning to Amanda, how does St. Luke's Mission Farms handle empanelment?
Thank you, Joe. Yes, one thing that we do, it's really pretty simple. Every patient that walks through our doors, every patient that calls our clinic, every patient who sends a message through the portal or contacts us in any way, shape, or form, we look to make sure, to see if they have a primary care provider listed in Epic. There's a special field we have that's displayed prominently in every patient chart that shows who that patient's primary care provider is. If that patient does not have one selected, then we work with them to put them in touch with the primary care provider of their choice. So that is really the majority of how we do it.
So do you engage your providers and care teams directly in reviewing their active patient lists?
We do. Another good question. Our providers, particularly at the end of each calendar year, as they are looking at their performance on a variety of quality measures and, as they're looking at the list of patients who are attributed to them who maybe have not been in yet to have an annual Medicare wellness visit, as they were reviewing those lists, they become very engaged and often, and that's where they then would reach out to us at the system office if they are seeing patients on their patient list who really aren't their patients, and we work to get that corrected.
Thank you so much. So we mentioned earlier that we're going to draw upon the experience of practices that started CPC Plus in 2017 as much as possible. To that end, we're going to be sharing some key questions that were asked by those same CPC Plus practices as they got started. You can actually find the full body of Q&A questions since CPC Plus launched in 2017 on CPC Plus Connect via the Knowledge tab. As a note, if you ever have a question, using the Knowledge tab on CPC Plus Connect to search through all the relevant Q&As is a great place to get started. So, question, can I refine my active patient criteria? The answer is yes, you absolutely should. You and your practice should develop a process to really identify who is and who is not a member of your practice panel. And a subset question that we saw over and over again is, can you exclude deceased patients? And the answer to that, again, is yes. For the purposes of your patient panels determined clinically, you should absolutely exclude deceased patients, assuming that's something that you can effectively track in the EHR. So, next question. Should we impanel only our Medicare patients or all of our patients? CPC Plus is a practice-wide transformation. There is no even feasible way to try to segregate the transformations out on the basis of payer coverage or what plan a specific patient falls to. So you should absolutely impanel all of your patients and then just treat them in the same clinically. The second change concept is improving access to ensuring timely access to care. My apologies. Improving access means working to diminish or remove appointment backlogs or any delays between the initiation of an appointment request and when a patient can be seen. To start this work, your practice can implement change tactics to improve timely access, such as expanding office hours, providing 24/7 coverage to ensure that your patients can reach the licensed practitioner who has access to their medical records, providing patients with same-day or next-day access to their care teams, initiating secure messaging for patients, or establishing alternative care delivery services that meet your patient population's needs. Rather than get caught up in the weeds of each of these change tactics myself, I'm going to again invite Amanda to help illuminate how St. Luke's Mission Farms has been working to improve access to care for their patients. Amanda, can you share how St. Luke's got started with offering the same-day appointments that you mentioned earlier?
Yes, Joe. I think it was a situation where we pilot tested it at one or two of our practices, and then in the spirit of continuous quality improvement, we tweaked the process as we needed to. I know that we have been offering same-day appointments for quite some time. I think that was one of the original ways we worked to expand access. And now I'm really happy to say that we have built upon that. We also now have a virtual visit option for patients through an app called St. Luke's 24/7. I will tell you this is new for us. We've just really started to offer it in the past year. Utilization so far is really not that high, to be quite honest, so we'll be working to increase utilization with that. I know I mentioned earlier that we have a pretty robust patient portal. I think right now we've got about 50 to 60% of patients registered to use the portal, and like the other virtual platforms, one of our challenges is that currently only about 25 patients are using it on a regular basis. So that's an area where we need to make improvements, and we'll be working to do that in 2018 and beyond.
So just as a quick question of clarification, you mean 25% of patients, not 25 patients total, right?
I'm sorry, yes. Thank you, Joe. 25% of patients, yes.
And then actually a question about that. So having 40 to 50% of your total patient panel enrolled on a patient portal.
Yeah,
and even
50 to 60. Mm-hmm.
Oh, 50 to 60, my apologies. And then having 25% actively engaged there seems really, really positive and actually high compared to what we see in a lot of practices. Can you share some of the strategies that Mission Farms use to engage patients and help sign them up and get them activated on their patient portals?
Yes, happy to do that. So we've tried to find a way to make it fun for our clinic staff, even kind of hosting friendly competitions, if you will. I mentioned that Mission Farms is one of 10 practices we have participating in CPC Plus, and what we did at one point last year is we had each practice competing to see, what percentage of patients they could get registered for the portal over a certain period of time, and then the practice managers got bragging rights, and there were pizza parties and things of that sort. So it really did become a fun competition among the practice teams. The front office staff, of course, are very involved every time they're checking in a patient. If they notice that patient does not currently have access to the portal, that the patient is encouraged both by the front office staff, but then our providers are engaged as well, and recognizing that patients are more likely to do something if their primary care provider is encouraging them to do so.
So building in kind of an ask around signing up for the patient portal at the front desk as patients sign in, and also actually into the review processes. Do you all use MAs to kind of take a patient out once they're done through the exam process?
Yes, we do. MAs are a very, very important part of our care teams, and the MAs are engaged. In fact, the MAs, I think, are the folks on the ground who really are helping patients register at the highest rate.
So getting the front office staff and MAs engaged at both the beginning and the end of an in-person visit, that's something that any practice can do, regardless of size or system affiliation, right?
Exactly. Yes.
So then a question about 24/7 access. How does Mission Farm handle providing 24/7 access? Do your providers take calls? Do they maintain a call pool? Or do you contract for external coverage service?
Yes, really good question. As you mentioned, there are different ways that we can provide that 24/7 access, and the method that we have chosen is to keep everything in-house. So we do have a provider on call 24/7, so patients know that if an issue arises outside of our normal clinic hours, which remember we have expanded hours, and then also we have a walk-in visit availability in addition to the same-day appointment slots. But our patients, we work really hard to make sure they know to call us if there's an issue in the evening, on the weekend, when maybe the clinic is not open, and that they will receive a call back from the on-call provider within half an hour. The providers then, of course, have 24/7 access to all of the patient charts, so they are able to document that, outside of business hours care that they've provided directly into the patient chart.
Thank you so much, Amanda. So then moving on to some of the questions that we saw early on for the 2017 starters around expanding access. One thing that came as a surprise is the question, what are expanded hours? And the reality is that there's no set definition. Again, remember, there's no right answer for any of these change concepts or practice or transformational processes. It really is just identifying an opportunity that best meets the needs of your practice. If your provider staff, all happen to be early birds, you have a mixture, you can figure out what expanded access schedule best meets the real-world daily reality of your practice. There's no arbitrary requirement that your practice is open at 7 a.m. and close at 7 p.m. to count as expanded access hours. So what types of visits are considered alternative care? This is another thing that we saw regularly on CPC Connect, at learning sessions, at virtual sessions. So I'm actually going to read this one out. Examples of alternative care may include, but are not limited to, e-visits, telehealth, telephone visits, home visits, and group visits. So basically, you need to think of what care delivery models break outside the four walls of your practice and outside the structure of the traditional fee-for-service driven in-person visit to identify what alternative delivery model best meets, again, the needs of your practice and your patients. The final change concept under access and continuity is for your practice to optimize continuity for care for patients on an ongoing basis. Care continuity is at the heart of comprehensive primary care. At its core, it represents the ability of your practice and your clinicians to know and care for your patients over time. Helping practices focus on optimizing continuity of care is actually a great example of how CPC Plus continues to be refined and improved as we all work to co-investigate strategies for transforming primary care. The clinical delivery requirement is that practices should begin to organize by practice identified care teams responsible for a specific identifiable panel of patients to optimize continuity. But with 2018, we're working to ensure that continuity is not being taken for granted as an underlying factor of other comprehensive primary care functions or change concepts. To make sure we're working off the same page, we've worked to provide an effective framework for you all to more intentionally measure and improve the continuity of care you provide for your patients. So, what steps should we take to ensure high rates of continuity in our practice? It may seem trite or cliche, but really the first and best step is to organize the care you provide into care team structures, making sure that everyone who interacts with the patient has clearly defined roles and responsibilities, and you understand when and how they're communicating with your patients to make sure that there's no communication misses or gaps that occur. Amanda, actually on that note, can you share how the care teams at St. Luke's are organized? Earlier you mentioned that you have care coordinators, that the MAs are integral as part of the care team, but kind of how is that structured?
Yes, another good question. So at Mission Farms, our care teams are primarily led by physicians. Some of those physicians have collaborating nurse practitioners. The care teams are supported by either one or two MAs, and then each care team is also supported by a care coordinator. The care coordinators focus on both the episodic and the longitudinal care management for those patients who need it. And I think in a nutshell, that's how we do it. So I know that you have an option, to empanel by provider or by care team, and we happen to do it by care team.
Thank you so much. And with that, we're actually going to use most of the remaining time to answer your questions related to access and continuity. And I will ask that everyone try to focus any questions you have into function 1, so related to access and continuity. But of course we understand that you're getting started, you're really excited about CPC Plus. So we will field questions as best we can, but particularly those related to function 1. Again, if you have any questions that we are not able to address today as part of this Q&A session, please reach out to CPC Plus support or bring them to the next office hour session or post them on CPC Plus Connect. Now, I'm going to invite my colleague Jen to get us started with the questions that you all have already been asking of Amanda.
Hi, thanks Joe, and hey Amanda. Thanks so much for everything you've shared with us today. Really appreciate it. Once we started talking about some of the alternative ways that you're giving access to your patients, the questions really started to come in from the participants. And I'm going to just start with one here about the portal usage. You did speak to this quite extensively, but there was interest still in how you engage the patients in the portal usage. And you had talked about how the providers get involved as well as a competition with the front desk to and with the staff to get people engaged with patients. Do you have any other pieces about the portal usage that you would share to help engage patients?
Yes, I think it's always important to, as you're encouraging patients to consider registering, to assure them that it is secure, because there's still patients who question whether is it really safe and secure for me to send my medical information electronically to my primary care practice. So just assuring them that it's secure. Also maybe even giving them a few examples of how it can make their life easier, to be frank, how other patients are using the portal to message their provider directly, and then from time to time, preventing them from having to take off work and rearrange their whole lives to come in for a face-to-face visit. We know that face-to-face visits are not always necessary. So I think those are just a couple of quick ways that we've been able to increase registration and utilization.
That's great. Yeah, you shared a lot of great information about that, so thank you. And then another question about was about why you chose an app for online appointments rather than some other program, and did you build that app internally? So if you could speak a little bit more about that process that you were speaking to about the online appointments.
Yeah, so I will tell you that we launched the St. Luke's 24/7 app prior to my joining the staff. So I will share what I know, and then if you have additional questions beyond that, please, I've let the moderators know they are welcome to share my email. I am happy to obtain further details and then share that with you offline. So the St. Luke's 24/7 app, I believe, is something that we contract with a company called MD Live to provide. So St. Luke's physicians can participate, but then also MD Live contracted physicians are able to do so as well. Those appointments, and I think the question might be getting more at, why don't we use Skype or some other platform? Is that really the intent of the question? I want to clarify.
I just have what's typed in here, so I'm not exactly sure what the intent is. So if there's a follow-up question, please feel free to type that in. But I think they were just interested in that platform and how you chose to use it.
Yes, so I know that there was an extensive process reviewing all of the different secure and platforms that are available on the market currently, and I know that St. Luke's went through a very long, extensive process in reviewing and selecting the app that they thought would work best for us.
Okay, great. Yeah, and if there's any additional information, I'm sure they can follow up. Even on CPC Plus Connect is always a great place to pose questions for follow-up. So another question was, how did you start your care teams initially? What was your process around initiating that concept?
That is another great question, and to really share with you, our care teams are evolving. We are in the process of adding a second medical assistant to some of the care teams, and those care teams are selected based on a variety of factors, including patient panel size. But we recognize that some patient panels are large enough that we really do need a second MA supporting that whole care team. So this is a model that we've rolled out, like I said, to some of our primary care providers, and we'll be adding another MA to other teams in 2018. I'm starting to maybe think about some of our other CPC Plus practices as well. We do have one practice, not at Mission Farms, but one of our other practices where the care teams look slightly differently, where we have primary care physicians that are then supported by LPN. So what we've done is we've really looked each practice, and Mission Farms, we did this as well, has looked at the patients and the community that we serve, the providers we have on staff, and determine what care team model is really going to serve best.
I think that's a great point, because there is no right size or look that's going to fit each practice depending on your resources and your patient needs. And so developing that care team, and like one question has come in about the ratio of the care team personnel to physician, and I think that is really what works best for your practice and your patients to meet these needs.
Exactly, Jen. And as Joe mentioned earlier in the presentation, CPC Plus, and we appreciate, is not too prescriptive on exactly how we form our care teams and how we implement the care delivery changes and transformations that we make. And I know that's something we really appreciate.
Well, we really appreciate you sharing that and being such a champion for the program. And as a follow-up to your patient portal question, I know we talked a lot about how you get patients signed up for it. I think it's one thing to get them registered, get them to sign up and put their names on there and get an account, but then do you actually get patients to use the portal? Do you find that there is a disparity between signing up and actually getting them to use it?
Yes, we do. I know that I mentioned earlier, I think the latest estimate is that we have about 50 to 60% of our patients at Mission Farm who are registered for the portal, and then of those, only about 25% are really regular users of the portal. So I think that's not a surprise to us. I think that those statistics would hold true for really any clinic across the country, just by the nature of human behavior, and there's differences in patient preference. So that's where we're at, but I think there's room for improvement and increasing patients. I think what we have seen though is once a patient does log in for the very first time and maybe perhaps makes their next appointment via the portal or sends their provider a message, they experience how easy it is and again how it makes their lives easier, and then they come back and start using the portal even more frequently.
That's great. And I know that's a continuous work in progress that you and practices do as patients get familiar with that process. And I have one additional question here about, this person's asking about your process for orienting your patients to your practice hours, to when they should call you, what your office hours are, things like that. Do you have a formal communication that you share with your patients when they first come in or sign somewhere? How do you communicate and orient patients to those logistics of your practice?
That's another great question. And one of the ways that we do it at Mission Farms is through a simple patient brochure, something tangible that they can take home with them. Our front office staff, make sure to catch those patients who are new to the practice and does not let them leave without having one of those brochures. And in the brochure, as they're handing it to them, we often will highlight, if you need care after hours, here are your options. So it's pretty simple, really. That's good information, I think, because sometimes we overlook some of the processes that we have available to us, and sharing that information with our patients will really help this process. Yeah, so, and then I do want to add that our website is another really important venue of communication for orienting new patients. We refer to our website quite a bit. We update it on a regular basis. In fact, we just updated it a couple of months ago. So recognizing that most people are online, that is another important place that we share information about our providers. We have nice bios of all the providers. Again, we reiterate to patients that they can reach us after hours. They can, that website also, of course, links to the patient portal. So that's just another way we do that. That's great. And the brochure that you were mentioning, is that something you would be willing to share maybe on CPC Plus Connect for other practices to take a look at and possibly use some of your example? Yes, we'd be happy to do that. Great. So just another plug there for the CPC Plus Connect is a great way to share resources as you all collaborate over time throughout this process. So for right now, I'm going to go ahead and pass this back over to Joe, and he has some additional questions, I think, to follow up with you. And if I have something else before the end, I will jump on in. So with that, I'll turn it back over to you, Joe.
Thank you so much, Jen.
Thanks.
Actually, first we'll have a couple questions of clarification. So there are a number of people who are asking about the difference between empaneling by provider or practitioner and empaneling by care team. So I'm going to use a question that came in as exemplary for this. Tara actually asked, how do you empanel patients in a small practice when all providers would be part of one care team? Our our 3 practitioners have different schedules where only 2 are here at any given time, but we just have 1 patient panel for our office. So this is a great case for empaneling patients at the care team level, not by individual providers. If the 3 practitioners share responsibilities and work in a continuous, ongoing fashion with the full patient panel, then yeah, it would be that isn't a panel assigned to a care team. That's one of the differences between assigning it to individual physicians or APRNs versus doing it at the care team level. It's just a way to provide flexibility for you at the practices to figure out how you want to define your panels. Another care team model that is fairly common is for a physician to directly collaborate with an APRN or a PA, and they would share responsibilities for a single patient panel. Another question for clarification that came in: what needs to be accomplished by year 1? You mentioned everything that doesn't need to get done within the first year. So let's take a step back. There are set requirements for each program year for each comprehensive primary care function. For access and continuity, I would recommend that you revisit the slides that lay out the clinical delivery requirements. But again, those requirements are broad and intentionally structured that way. So how you specifically meet them is up to you. How you pace the change and the transformation across the year is up to your practice. None of them are things that you can handle and just get done overnight. But figuring out how to actually accomplish, for example, meeting 95% empanelment of all your patients is something that your practice needs to figure out. There's no one right answer for that. But to be clear, the clinical delivery requirements are set requirements for the program year. I would strongly encourage everyone to look at the implementation guide, of which a updated version will be coming out very shortly and available for you very shortly. That is where you will find the full details regarding the clinical delivery requirements for your first program year, 2018. And then, Amanda, this is a technical, semi-technical question. Have you guys had to adjust Epic to fit the CPC Plus model much? If so, what are some of the examples of things that had to be added or adjusted around access and continuity, or empanelment, actually?
Yes, we have. In fact, speaking of continuity, we have recently built a report in Epic so that we can begin to really measure continuity of care for this year. We are currently testing the new continuity report that we have created. So that's just one quick example of how we have had to adjust Epic. Another way that we've done that is we've had to build out the specific CPC Plus electronic clinical quality measures, or ECQMs, for CPC Plus to make sure that we are monitoring our performance on those quality measures throughout the year. Those are just 2 quick examples. I could share more, but I think those are the big ones.
Thank you so much. So I think that we are actually at time for the available Q&A, but I will recommend anyone that didn't have a chance to get their questions addressed to Amanda or the faculty or have further questions, please feel free to contact CPC Plus support at the information provided on this slide or post on CPC Plus Connect. So with that, we're going to transition really quickly to kind of wrapping this up. So as I mentioned, this is the first of a 5-part webinar series. We'll have one every Thursday from now on out until February 1st. So the next one, next week's, is care management. Following that, we will have a webinar addressing comprehensiveness and coordination, followed by patient and caregiver engagement on January 25th, and wrapping the whole thing up with a discussion around planned care and population health on February the 1st. All webinars are going to be scheduled or are scheduled for 4 p.m. Eastern Time. We tried to schedule in such a fashion that it meets the needs of practices across the whole country, and we have feedback for that. Please let us know. We also really strongly encourage you to continue engaging with the CPC Plus learning community as a whole. So as mentioned earlier, we're all co-investigators in this process. So review the resources that are available through CPC Plus Connect, the publications that you are receiving via your biweekly newsletter. You can find tools that other practices have shared or recommended on CPC Plus Connect. Continue participating in learning events. So there is a really high ratio of active participants on today's webinars versus the registered numbers, so you guys are awesome. And then finally, always feel free to ask questions, either to the community at large via CPC Plus Connect, at your in-person learning sessions, to your regional facilitators, or to CPC Plus support. With that, we're going to just kind of wind down quickly. So my key takeaways really are that CPC Plus, you should come into this program really understanding that it is a flexible, supportive environment intended to help you meet the goals that you set for yourself and your practice. There's no set minimum requirements in terms of check the box. It's intended to give resources and support to you as you try to lay out your own path forward. There's also just plenty of opportunities to continue to grow and refine what you want to get out of CPC Plus. So with that, I'm going to invite everyone to complete our short online survey. You're going to be seeing it pop up in a browser window on your screen presently. It should take no more than 2 minutes to complete. We really do appreciate the feedback that you provide. It helps us better tune and better develop these presentations for you so they're not as boring or so it flows a little bit better. And then again, keep the conversation going on CPC Plus Connect. With that, I'm actually going to formally bring the webinar to a close, and thank you all again for taking the time to participate and sharing in this learning. Have a wonderful day.